Welcome back to everyone in our audience. We're so glad to have you back. We're going to be talking about health data sharing advances going from connectivity to interoperability. I have a wonderful panel of health leaders, healthcare leaders, and experts. And I think what I'd like to do to make things simple is go around the virtual circle here and have each person introduce her or himself, their title and role, and just a bit about their organization and its connection to our topic. And then we'll plunge in and talk about the topic itself. Heidi, if you don't mind, would you like to go first and tell us just a little bit about yourself, your role, and your organization?
Sure. So my name is Heidi Kriz. I'm an assistant director here at Regence. And just to preface, a lot of people know us as Cambia Health Solutions. Regence is the health plan under the umbrella of Cambia. So I oversee our medical policy area and a lot of the research that happens within that realm. And then the second hat I wear is in the prior authorization transformation space. So in 2018, our CEO at the time started a prior authorization transformation program, and I've been a part of that leadership group since then and have really drove a lot of the transformation we've been doing in interop, artificial intelligence, and launching our electronic authorization workflows, and more recently getting expansive in the interoperability space.
Wonderful. Perfect. So Anna Taylor, welcome to you.
Thank you. My name's Anna Taylor, and my title is Director of Operations, and I work for a accountable care organization called Multicare Connected Care, which is a subsidiary of Multicare Health System. And our ACO is responsible for 350,000 lives. We have about 4,200 providers, both employed and independent, within our network. And we are on the journey of interoperability, realizing that it takes a village to keep a person well. And we know that we can't do it all ourselves. So we have to be enabled to connect data technologically to be successful.
Wonderful. And Anna, I know that you're a subsidiary of Multicare overall. How big is Multicare overall in terms of hospital facilities, clinics, that kind of thing?
Yeah, we have 9 hospitals and over 150 more plus of the ancillary and ambulatory services in place.
Wonderful. And you're based, is it Tacoma?
Yeah, our headquarters are in Tacoma, Washington. And then we have hospitals in Spokane and up and down the I-5 corridor here in the Puget Sound area.
Wonderful, thank you. So, Rajesh Godavarty, did I say your name correctly?
That's welcome. Thank you, thanks, Mark. People call me Raj, that's probably easy. So, Raj from MCG. I have been with MCG since 2003, primarily as a technology person. Over the last few years, I have jumped into the interoperability bandwagon and the healthcare side. So right now I am the AVP of technology and interoperability, leading interoperability efforts where MCG has been used by payers and providers to exchange the information for prior authorization scenarios and medical necessity scenarios. So I have been actively participating in many of those HL7 organizations.
Wonderful, thank you. And I know one of your colleagues in our previous session explained about MCG Health and its origins with Milliman, correct?
That's right. Yeah, so MCG was born out of one of the Milliman's subsidiary and then eventually acquired by Hearst organization in 2012.
Okay. Wonderful. And you work with all types of patient care organizations, correct?
That's right.
Okay, great. Well, panelists, welcome. It's great to have you. Let me do like a half-second level set here. I think this is a particularly interesting moment with regard to data exchange and how we think about data, because as value-based care delivery, payment, and contracting all move forward, patient care organization leaders, health plan leaders, and all the other stakeholders are realizing just how crucial it is to be able to effectively share data. I think they're realizing how challenging it is to get it all right and complex. And then here we also are still in the middle of a pandemic, and there have been a lot of challenges with that. People going virtual and care going virtual, a lot of moving parts to this, correct? And so one of the overall challenges or overarching challenges is, how do we get all the trains moving in the right direction? How do we make these processes not super duper uber complicated, right? And so I think I'd like to begin by asking, where are your organizations? I'm going to start with the provider and payer organizations, and then I'll ask you, Raj, to give us a kind of a nationwide perspective based on the clients that you're working with. But on that journey of 1,000 miles, where are you right now? What are the biggest challenges that you're facing with regard to smoothing out all the challenges around collecting, analyzing, sharing, storing, resharing, and using data? That makes sense. Anna, if you don't mind, I'd like to start with you. And by the way, I have to say, you have a pretty large ACO in terms of covered lives. That was great to hear that you have 350,000. So often we hear, I'll interview, or one of my team will interview someone who says they're with ABC ACO, and we ask how many lives. Well, we've got about 5,000, which is, and I don't want to disparage that in any way, but they probably don't have the level of depth or breadth of experience that you and your colleagues do. So you're working with a lot of lives, working with a lot of data. What are some of the challenges that you're working through right now? And what are some of the processes that you're, including governance processes, that you're using to help work through those challenges?
Yeah, managing an ACO of that size, especially with independent providers who have various EHRs. At one point, I think there was 45 different EHRs
wow.
Within the network that we're going, oh gosh, how are we going to get all this data? And in the beginning, I missed 2 hospitals there. Our behavioral health hospitals are also included, and we have 2 of those. So we have a total of 11. I had to do a quick cross check on myself. But the challenges and what we face in delivering on the whole premise of population health, which is to keep people well, and is that it's big data. And we're a provider organization. Our business is providing care. So now we have to transform ourselves into and partner with others to help transform ourselves into managing big data, because we can't do this type of work without it. It's about having the intelligence to know where the resources need to go, where the equity needs to be changed, where we need to give others more than we give the ones who are well in order to be successful. So for us, the biggest challenge right now is figuring out, how do we do that? How do we transform ourselves from an organization that traditionally was in fee-for-service, and now we need this intelligence to make this happen, as well as we need intelligence at scale and partners in that intelligence. So not only are we dealing with the 45 EMRs, we're also dealing with data that comes from community-based organizations like food insecurity, housing insecurity, all of those organizations that support closing gaps in the social side of medicine. And then we also have partners like our payers who are here today, who we need the data and information they have for us to be successful in managing total cost of care. So when we take on risk as an accountable care organization, the way we know that we're performing appropriately is by measuring 2 quality standards: total cost of care and utilization. And we understand who needs what resources as a patient. Yeah. And so that is what we've been faced with right now.
It's a tall mountain.
Yes, it is.
Heidi,
worth climbing.
Yeah, worth climbing. Absolutely worth climbing. So Heidi, you've heard what Anna said. Tell us a little bit about the challenges from the payer side, and also about this whole collaborative thing. How is that working out? What are the challenges in that? So I guess there are two sets of challenges. One is just overall challenges, and then the other is as you collaborate with providers, what are you facing, and how are you handling all of those?
Yeah, I think as an organization, the position that we are in is, you know, a health plan has so many facets to it, and it's where do you invest the money and when do you invest it? And really the core of what we're doing is doing the best for our members on our health plan and working collaboratively with our provider partners. And so we've had a lot of leadership conversations about what use cases do we adopt in the interoperability space? What's going to bring the most value to our members? And will the providers come along? So, you know, we can develop everything in the world, but unless the providers adopt it, then it's not valuable in the end. And I think that's where, you know, that collaborative piece, working with our providers and understanding what do they need, what do we need as a health plan, and how do we get to consensus on how best to move forward and which use cases to move forward in the interoperability space.
Yeah.
I think that, you know, as a health plan, one of our big challenges that we are continually discussing and need to solve for is probably around the privacy piece of it. You know, we have a lot of startups coming to us trying to solve all these different interoperability problems. And so how do you know who you can trust? Who's going to provide that security in place to protect our members and their health information? And then also, you know, there's a lot of different APIs to connect to. So where do we go to find them? How do we connect to them and get the right data? So those are the big challenges right now. You know, we're also really engaging in just with our public affairs and regulatory team around how can we collaborate and drive some of the changes that are taking place so we can, as a health plan, align with those and help shape them, again, at the end of the day, protecting our members and really giving our providers something that's valuable.
Yeah, absolutely. Can you just share for one moment, how do you frame the data governance aspects of this from your side? Because I think, you know, we talk most often to provider leaders. I love to talk to health plan leaders, and I love to find out what it looks like from the other side, as it were. What are the key data governance lessons you're kind of learning that you're applying to the collaborative aspects of this?
So I think that's an evolving conversation. You know, we're treading new water right now in a lot of ways and trying to bring our different teams to the table. So our privacy, our compliance, you know, Raj, who's with MCG, is one of our vendors that we're using in the PA transformation space. And we've been going back and forth on the data and protecting it. And I think it's evolving as we go. And as an organization, we are trying to develop internally who is our governance team, who are the decision makers. And I think that's really, at the end of the day, a really multidisciplinary stakeholder group. We need all facets of the health plan to come to the table, and that's what we're working on right now.
Wonderful. So that provides a great segue for Raj. Raj, when you look at this, and I'm so glad that you're working with organizations like Regence, what are you seeing nationwide as you work with health plans and providers to gather the data, analyze it, help them share it, help them use it? What are some of the big challenges that both providers and plans are facing? How are you helping them with the data governance and management and project prioritization issues? And yeah, okay, let's start with the biggest challenges.
Yeah. So when you think about, you know, the word interoperability, you know, I would like to phrase functional interoperability. What does the functional interoperability looks like when you exchange the data between payer and providers for certain use cases. We call value-based delivery use cases, right? So if you take the example of prior authorization and the use cases around that, right, you have a fundamentals of interoperability. What is the structure and semantic of the interoperability? Like, are you providing the data between provider and payer in a meaningful context that can be used to make decisions, right? So we call about data liquidity, right? Everything that provider is capturing is good enough to pass along and handle it to the payer so that they can use it and use the technologies to automate the decisions. So while the interoperability provides the structure and semantics using a lot of bodies and organizations and committees, HL7 Da Vinci is one of them we are working with. And then you have the Da Vinci is one of the committee provides a blueprint to say how you implement it in real world. Because there are a lot of organizations provide the structure and semantics. Very few organizations provide how do you take it to the level you can implement between a payer and provider to show them the fruits of it. So in all this process, data is the new gas, right? They say that, old days, like, gas is the gold. Now you have the data, you are gold. So everybody wants the data, right? How much of the data we ask providers, you need to capture all the data you can. They're like, how much do you need? Like, providers have so much time with patient, how much do I need to document? Payers are like, if I get all the data I need, I can make the decisions. In this process, the governance, who are we giving access to? Who is taking the data? What are they going to do with it? This is where when we take the value delivery use cases, when we present to Anna Taylor and Heidi between providers and payers, what are we trying to achieve with this prior authorization use case? What exactly this means? So we use the word integration and clinical context. When we integrate systems across the board with interoperability standards, we talk about what clinical context you need. And the governance is that context that you define for the use case and say, okay, you're getting the context of the patient that you're needing for that particular authorization. You're not asking for last 3 years of history. That's none of your business. So you bake the governance in the process that you define to some extent. It only works so far. And then payers would need sometimes, I would like to know last 2 months of the BMI as well, right? Then I can make other decisions as well. So this is like Heidi pointed, this is evolving, right? But you start small, and you have to build the trust in this process that you're not adding a lot of, one payer said that you don't want them to do anything now, you want us to do all the stuff. So we cannot do that. So we have to start with the clinical context for a particular use case and see how it works, how much data you need. Is the data you need is good enough to make the decisions? And then you add on top of it. So we don't really put the governance outside of it. We put the governance inside the process we define, and we slowly evolve use case by use case before we boil the ocean.
That makes sense. Anna, I see you nodding a lot. Would you like to comment a little bit on that? I thought that there was a lot there to ponder.
Yeah, absolutely. I was just on a phone call with another payer, and we were discussing use cases. And I said, I need it in writing. What are you going to do with this data? Or what do you need to accomplish? Because that really governs what I'm going to prepare in that semantic interoperability conversation.
Yeah, absolutely. Yeah. Heidi, what are your thoughts listening to what Raj just shared with us just now?
What I was actually thinking about is going out with interoperability in our use cases. We have 2 pilot providers that we're working with, and obviously multi-care is one of those. And we knew that this is new. And so for us, we really put together a framework of which providers we were going to engage with when we started down our interoperability use cases. And I think, we're in a new space. And so people have got to learn to trust each other.
Yeah.
And part of our framework engaging our providers was those providers that we had, you know, a really collaborative relationship with and strategic investment in. And we knew that they would trust us in the use of their data and their patients' information, who are also our members. We both have a vested interest in protecting that information and exchanging it to better the process for everybody involved. So that was definitely part of our framework when we were choosing our provider partners. And my hope is, you know, as we expand, you know, there'll be more governance around it, and maybe, you know, from a federal regulatory perspective, that will help guide some of that as well.
Great. Speaking of federal, you played right into my hands. I was next going to ask, I know that TEFCA is complicated, and I know none of you are like sitting in Washington, D.C. next to the federal agencies talking to them every day, but what is your perception of the potential of TEFCA? I have to say that with regard to the fact that we just posted something yesterday. CMS Administrator Chiquita Brooks-LaSure yesterday just posted a really interesting, they call it a blog. CMS has its own blog. And it was about how they can make TEFCA, when it finally comes out, better for all of this. That they're hoping to make it more flexible, to have it help facilitate social determinants of health data inclusion and use and sharing, and just to make data sharing easier for precisely the kinds of use cases that we're talking about here. What is your understanding, and I'll go to all three of you, but maybe Anna and Heidi first. What is your understanding of the potential of TEFCA to help you in all this? Are you pretty favorable in your perception of what may happen next year? Maybe Anna, if you want to go first.
Sure, I can go first. I think one of the blockers, and not in a bad way, but one of the challenges that we face in the industry in making this semantic interoperability possible is that we've been on the EHR since 1999. We were an early adopter of Epic. And that is an asset for us 100%. But the way technology has evolved, and now needing semantic interoperability to be successful in new financial models, that means that data needs to be available in that way, shape, or form. But that is not how it was built in the first place. Yeah. So having EHRs at the ready instantly to do this is a challenge, because that API might not be available. We may not be able to do that. And so with this common agreement that we would put into place to agree that these are things that are going to be available, this is what they mean, semantic interoperability, then we should be able to achieve this. So if that happens, I do think it'll put some more pressure on the EHRs to maybe move a little bit faster in what APIs are available, or as fast as they can. It takes a long time to develop those. But that's what I see in the future.
Okay. And Heidi, I want to ask you also, but let me just very briefly, I'm just going to read two quick paragraphs of what Administrator Brooks-LaSure wrote yesterday to kind of help us level set what they're saying, what the administration is saying. Pardon me. She wrote, "The COVID-19 pandemic exposed many shortcomings in our healthcare system, especially the ability to quickly share and use reliable data to better understand the health needs of all people across the country. This need for more accessible data is why CMS remains committed to making healthcare data flow more freely and securely among payers, providers, and patients by laying the foundation to foster a more connected healthcare system. CMS is working towards this goal by increasing and advancing healthcare data exchange functionality to better inform decision-making for patients and their providers, support, improve improve patient care and reduce the administrative burden on providers and payers. And she talks about the fact that she says, we are also exploring with ONC how the Trusted Exchange Framework and Common Agreement, TEFCA, nationwide network can be used to support a variety of CMS use cases. So, and they're exploring the use of a standards-based API based on FHIR. So it all sounds good, and I hope that they can accomplish this. Heidi, your thoughts based on what Anna just shared and what I just read?
Yeah, so I haven't been intimately involved in this piece within the organization. One of our VPs in technology has, but what I would say is I agree with everything Anna said. And as an organization who is really promoting Da Vinci, we really need to make the FHIR-based standards available for clinical data exchange. And that's the direction we as an organization would really like to go in the interoperability space. You know, you didn't bring up information blocking, but that's something else I would probably note. We actually had a conversation about it this morning. You know, as a health plan, we believe we're not a health information network as defined by the CARES Act, but we're definitely interested in, you know, how this impacts the EHR vendors and ultimately us as the partner trying to obtain that data from the EHR, you know, especially in our Da Vinci use cases. So it'll be absolutely pivotal that, you know, the information blocking doesn't inhibit us, especially from a financial perspective in achieving our goals.
Yeah. You know, the thing about the information blocking is it's like public littering. No one wants to admit they've ever done it, right? And yet people are saying, well, it's happening. And of course, then you get into the whole, what is information blocking? But I love your comments. I think they're right on. And I think that we all really do need to work together to work out these details. Raj, do you have any thoughts on what Heidi just said, what Anna just said, and what I read from Administrator Brooks LaSure?
Sure. This trusted exchange framework, it is the sense of universal interoperability, right? Network to network connection. The framework or the agreement through which that you provide certain technology, you know, guidance to say you can easily flow the information from one network to another one. It looks like a dream for me. But the point is that when you think about implementing standards like this, right? When CMS and ONC, when they come up with patient access API, provider access API, you know, burden reduction using certain frameworks, you need interoperability resources. Develop it. You need EMRs to support interoperability technologies. You have outdated EMRs everywhere. Yeah. You have Epic and Cerners, and they're not anywhere close to some of these things we are asking for in terms of making things available using FHIR and API and structured data. So while you know the ONC selected, you know, Sequoia to govern this whole thing, while these things are there, I believe what the pandemic opened up with the telehealth, right? You have people, like you have so many pop-ups, you know, of these vendors to say we can do telehealth for you and this and that. None of them have this information about all the patients. So we are trying to put these things on steroids before we enable the fundamentals of the systems to build, you know, the technology required to do it. So government need to do, you know, probably you have to do another, you know, meaningful use kind of funding, right? Get the EMRs to the level of interoperability they get, and all the small EMRs as well to that level. You can't just fund the big ones and leave the others, right? Yeah. So you still see the disparity at the level. We are not even at the basics, and we're trying to, you know, finish the sentences here. So it's going to be a long path in my view.
Yeah. No, that all makes sense. What I'd love to do is for each of you just to spend about a minute and a half sharing with us in advance or two, if you can do briefly, that you're very happy with and pleased with that you've been involved in recently, where you've really made some progress in this area and you feel good about it. Anna, why don't I go to you first, and then Heidi, and then Raj?
Yeah, sure. So the biggest advance that we made is actually a very tiny use case. It was done off the side of death to see if we could do it, because it seemed like the right thing to do. And we had partners who wanted to do it with Regents. And we had a business case to support that and govern what we would exchange. So all the pieces were there to be successful. We were utilizing and participating in the Da Vinci project, and we chose to do data exchange for quality measures, specifically med reconciliation, to get that 1111F code to the payer more effective and efficiently, because it wasn't. It was a low-hanging fruit in a sense that the data wasn't getting there, and we could get it there in a better way with this. And we ended up, the results were we ended up doing that, and we improved compliance reporting by 40%, which is a pretty big deal, without even touching the provider workflow. It's just mining big data in a better way and exchanging it on a daily API, methodology. So it's really incredible the work done. And that particular thing was a tipping point for the organization to say, we can do this and we should scale it, and we should figure out how do we even do this more, and who else can we bring to the table and figure out how to do this better. And thanks to Regents for bringing us to the table in this conversation, because we wouldn't have known that we could do this without this use case. So that's really what I think the team would say they're most proud of. And certainly the tipping point for us was making that happen.
Oh, wonderful. That's great. Heidi, what are your thoughts?
Yeah, so I would echo the use case that Anna just mentioned, and then I'll add one more that we're working on with Anna and Multicare, and then another pilot provider that I'm very excited about. So it's our prior authorization use case. So we are in the process right now of launching an EHR-enabled prior authorization. And it'll be really exciting because there's several enhancements to that we're also collaborating with MCG on, and Raj and his team. So a provider will be able to access a PA, prior authorization eligibility, and code check. And if that code requires prior authorization, we'll tell them that. If it doesn't, then they'll know they don't need prior auth and they can just continue on with their services. If it needs prior authorization, then we're really excited to be able to surface that policy criteria set to show when it's covered and when it's not. And then additionally, we're going to pull the clinical requirements automatically from the EHR to match that policy requirement to get to coverage. And so the providers will not have to manually pull everything up, match it to the criteria, cross-check, make sure they've gotten everything that they need to submit to us as a payer to promote a timely prior authorization. And with that, really what we're hoping to do with other types of data and analytics running in the background is give them auto approvals, and for some services, point of care approvals, so that they can move forward with that service and that provider while they're in the office together. And I'm extremely excited about this, and really thankful that we've got Multicare and our other pilot provider to roll this out. And I am excited to say that, we're hoping to launch here in Q1 of 2022. So we're right around the corner, and it's going to happen.
Wonderful. Good for you. Kudos. And I can tell you, providers will be excited.
I hope so. Well, and it goes to the whole conversation we had earlier, which is we can build it, but we need the providers to come too and really try to make this better for everybody. And so we're hoping we're building something great, and the providers will want to use it, and it's going to make it better for everybody in the end.
Wonderful. Wonderful. Raj, I know you're working with many kinds of clients nationwide. Maybe just name one example of something that you can share that will be helpful for everyone.
Yeah. So in addition to working with Regents and Multicare, and we've recently rolled out this we call collaborative care solution, where providers can submit authorization requests to payers. So it's been 10 weeks we are in production, and the amount of excitement from one facility, every day we see 30, 40, inpatient auth requests that flows from payer to provider. And the exciting news is that about 12% of them are auto approved, right? So when you submit the request and it comes with approval, and we've shown this to another provider facility, hey, you should test this because they're on the same network. and they tested it without any belief. And when they saw first time everything is flowing through without fax and phone or portal, they were like, this is like an early Christmas gift for us. So there was a lot of excitement with even a first set of use cases we are rolling out. Mm-hmm. So of course, there's a lot of fine tuning to do, but within 10 weeks, we have seen things move from 12% to 17%, where payers and providers trust the data coming and fine tune what we can approve without doing a lot of due diligence, right? Yeah. So we've seen early success and excited to see next year when we roll out solutions with the regions and multi-care.
Wonderful. You're all doing really great work. I salute you all. What does the next couple of years look like, do you think, nationwide? I mean, you can certainly bring up your own organizations, but what does this journey look like a couple of years from now? Why don't I start with you, Heidi?
Sure. I think, at a national level, we're going to see a lot happening, as we've already talked about. I think there's going to be federal regulation coming down. We're also seeing a lot of state mandates getting talked about. And so I think, as an organization, we really want to be at the table to collaborate and inform a lot of what's happening in that space. I think that nationally, we're going to need continual organizational alignment, at the highest levels within those organizations, so everybody comes to the table. Mm-hmm. As you've heard us talk about, just some of our use cases, we've got lots of different organizations that have had to come together to solve these problems. So we've got our provider partners, us as a health plan, and many different teams within our health plan. You have MCG, we have our EHR vendor. All these organizations really had to commit at the highest level, the staff, the time, the resources to make all of this happen. And I think it's going to be absolutely pivotal as we move forward. I think too, as an organization, we're really hoping to have that continued commitment with our organization to drive interoperability forward. Yeah. We've been a trailblazer in this space. I'm hoping we can continue to be a trailblazer in this space and show people we can do this. I think it was really exciting. Anna and I presented at a conference a few months ago, and it was really exciting to see how many people came up to us, and they were so excited to see a payer and a provider collaborating together to solve problems. Yeah. And I think we need to see more of that rather than the historical silos of health plans and providers. So we're hoping we can blaze that and show others that this is possible, and we can do this. And then, for us as an organization, we really want to expand on our use cases. So as we say internally to our leadership, we've built the foundation. We've got the heavy lift. Now we need to, expand it. Let's engage more providers. And it's not as heavy of a lift after we build the foundation. So I think that's exciting. And then we're continuing to look at other Da Vinci use cases across the board as well.
Wonderful, wonderful. Anna, what do you think things will look like a couple of years from now?
Well, I 100% agree with everything that Heidi just said, especially the part about coming together, showing it's possible, and bringing more people to the table, making more happen, because the only way this works is with adoption. So in the next 2 years, I hope to see an increase in that adoption, especially with the providers. I know we're exhausted. We are so tired right now. And we are working to make our communities healthier every day and to really sustain being a community asset. And we understand that takes partnership. And so we are working to build those technology tools and pieces that we don't normally have. We were care providers. So 2 years from now, we'll probably have more of the foundations built that we need to scale to the 28 payers that we work with within our value-based contracts. And then on a national level, I really do see more regulation coming down, as well as more accelerators occurring to really get the experts to the table, working in partnership, competing over merit, not hubris, and really getting to the heart of interoperability, which is getting that information to the caregivers and to the patients and to the ecosystem that supports them.
Yeah, and I agree with you, and I have a couple of thoughts, but let me turn to Raj first, and then I might share a thought.
Oh yeah, so next 2 years, I think people like Regents and Multicare, the folks who are, I call innovators, like, they step into this, the risk zone where they say, we're going to try this out. We are not waiting for regulation to come. We are not waiting for something else to drive us. We see the value to deliver, an improved patient outcome. The dream is that when the patient is with the doctor, if you see the approval for your MRI, that's the ultimate goal, right? So things like, so they pioneered this one. And what I see next 2 years is that people are going to look at these stories and say, yeah, we can do it as well. We don't need to wait for the CMS rule to come. So I think the next 2 years is we're going to build what are the stepping stones to implement a change of this magnitude, using FHIR, using APIs, even the maturity of EMR supporting the standards. And we see there's a lot of movement happening right now. And for them to move, it's moving a beast, right? So for them to support all these standards, you're going to have the foundational piece and some of the pioneers proving the use cases, and then you will see proliferation. So people going after that.
Yeah, absolutely. And I'll just add, pardon me, I think, Anna, you're right. I think that there will be more regulation. My early sense is that this administration, especially this CMS, are going to move forward pretty quickly. They've decided what they want philosophically. They've already laid out, Chiquita Brooks-LaSure and Liz Fowler did a really interesting press briefing a month ago in which they talked about what their priorities are. And they laid them out all quite explicitly. They want to move toward health equity. They want to address social determinants of health. Anyway, there was a long list, and it was very clear, and they prioritized the list in order. So I think that will help them to move pretty quickly. And I think that this fits into that because they clearly see creating greater interoperability, functional nationwide interoperability, health system-wide interoperability, as supporting the cause of increasing and enhancing health equity in the healthcare system, right? By helping more patients and plan members over time. So I think they will move fairly quickly, actually. Let's just close. If each panelist could just give us one piece of advice for our audience. And our audience is diverse, although most in the audience will be providers from health systems. Just leave us with one piece of advice that you think our audience members might benefit from based on everything we've talked about just now and your own lived experience of this. I'll start with you, Raj, and then move forward.
So I would say organizational readiness and patience. So this is going to be a long road. Organizational readiness is key for everything. So you need to find a champion. You need to make sure you'll give time yourself to educate your organization, bring that awareness, and then tell them it's going to take some time to get there. So those are the two things I learned in the last 2 years.
Wonderful. Very succinct. You win a special prize for succinctness. Anna, would you like to share one good piece of advice with our audience?
Sure. From the provider perspective, I would say data governance is the two most important words moving forward in all of this. It's driven by the business, and you need your structures in place now so that you can start readying your data for this new technological advance. And then partner with your IT systems, whatever you call them. There's so many words, information services, information technology, performance analytics, whatever you call your universe. Partner with them. Let them know what you're trying to do on a business side so that they can ready the infrastructure to meet your needs.
Wonderful. And Heidi.
So I would agree with Raj. That was the first thing that came to my mind too, is organizational readiness and leadership alignment on doing this and devoting the staff time and resources. I think the second thing I would say that I learned, prior authorization is a very complicated workflow process, and a lot of people were skeptical if we were going to be able to do this. And it's exciting to say that we can. But what I would say is, I think starting small sometimes is valuable, and expanding on that, and really with our provider partners, it's what is a good start, and then let's keep making it better, because if we try to get to the ultimate endpoint, it's just going to be so complicated and hard and cumbersome that it's going to take a long time to get there. So for me, it's let's define what our MVP is. Let's get something out. Let's do it, and then we can keep making it better for everybody.
Yeah. And I think that's very wise. This is such a long, complex journey that you're all on, and early wins are important, if only to encourage people so that they feel, oh yes, this is doable. This won't take 2,000 years to do, right? It's a very, it's an area just absolutely ripe with opportunity, but it requires leadership. It does require data governance. It requires organizational readiness, everything that all three of you have mentioned. So I think you're all setting a wonderful example in the field. And I think this will move forward relatively quickly over time. And I think it will be interesting to see how the federal government interacts with this. But my guess is that this administration wants to move pretty quickly, and that they're aligning their priorities to support providers, plans, and all other stakeholders. So thank you all so much. This has been a wonderful session. I know I've learned a lot. I'm sure our audience has learned a lot. So Heidi, Anna, and Raj, thank you so much for your time, your wisdom, and your expertise today. Thank you.
Thanks, Mark.
Thank you.
Thanks, Mark.
Certainly.